So what we have here is we're an imaging informatics company, so we have a new functional test for spinal instability. We're both FDA cleared for lumbar and cervical. And really, if you think about this, so looking at the cases you were just talking about, the cardiologists have had, historically a battery of functional tests, where you guys really haven't had true functional capabilities from an imaging standpoint. You were talking about dynamic FlexX earlier, and looking at static in-range X-rays and trying to quantify function really with snapshots of the spine. Same thing from an MR standpoint, and it'd be supine or standing, and you try to quantify this profile. So what we have is taken the FlexX to a new era. So from a FlexX standpoint, they're ordered often, and obviously you guys know this. The volume from an MR and a CT, FlexX is actually ordered far more than that on an annual basis. So I'm not going to go into all of these data and the scientific data behind this, but I have a bunch of slides in case questions come up that we can come back to. But in essence, if you think about the FlexX, even the Punjabi and White work have talked about, the inability of FlexX from a clinical usefulness standpoint, that they don't provide a lot of useful data because, again, you only see the grossest of abnormalities, and they're often at the end ranges. What we found in our data and our published data is a lot of abnormalities and instability occurs mid-bend. A lot of patients that are in pain, and a lot of patients that go through a bend profile, typically under bend. And so in our technology, we actually have a FlexX, and then we have a controlled motion profile that we can compare the two. And so how we do this, we have an actual patient handling device. So this piece right here is an upright, and we have a lying unit. And what we do is we isolate the lumbar motion and isolate the cervical motion by fixating the adjacent complex. So the pelvic girdle will actually isolate. We'll bolster them in with these bolstering fixtures. So we screw them in. They basically hold the patient's pelvic area in place, and as they go through a bend range, all the motion is isolated at the lumbar spine. So unlike uncontrolled bend, and we can talk about the data behind this, uncontrolled bend, if all of us stood up, I ask you to do a flexion extension view, all of us would bend differently. If we're in pain, we're going to bend differently, right? If we have a specific pathology, we're going to bend differently. So by isolating the pelvic girdle, we're actually able to generate a controlled bend profile through a range of motion that everybody's going to bend the same. Now, when I say bend the same, I don't mean the lumbar spine is going to do the exact same thing, but we're isolating the motion at the lumbar spine. We do the same thing cervical. Individual would just sit down. Those bolsters actually bolster the shoulder complex, and then when you go through your flexion extension view of your cervical spine, right, there's not a shoulder protraction or retraction. There's not a lot of forward bend. All the motion's isolated at that segment. We use fluoro and not X-ray, so we take multi-shots of fluoro in boost pulse mode. Through that, we actually have lower radiation, about 30% less. This is a published paper in radiography that is about 29.6% less when you look at a one-to-one comparison between our FlexX and the standard X-ray FlexX. And as I mentioned, we're FDA cleared for lumbar and cervical. So within those data sets, both from our FDA data as well as active patients, we have thousands of patients that have gone through the test. As I said, the workflow here is the fluoro. We do an uncontrolled bend, so you get your normal FlexX outside of the patient handling device, and then we put them in the patient handling device, and they do a FlexX as well. So we have a direct comparison between what we call uncontrolled bend, what they do on their own, and controlled bend when we isolate the motion. These are actually reimbursed under existing CPT Category 1 codes, so it's a reimbursable test as well, and we have very good reimbursement relative to what you have from FlexX. Is pretty much a crosswalk over to an MRI code. And then we have published data, obviously, from an FDA standpoint, but in the Spine Journal of Spine, International Journal of Spine Surgery, a number of papers from just the specificity, accuracy, repeatability of the test. Our paper on the repeatability, both inter and intra observer and intra subject repeatability was the runner-up for paper of the year in the Spine Journal last year. So all these are recent. And now we're moving into clinical papers as well. So we have a number of physicians that are using this clinically that we're looking at direct comparisons between types of treatments, types of approaches, types of devices. We finished a paper that was published last year that looked at identifying the trajectory on the vertebral body where a specific cage would go and how the trajectory impacted what the motion profile is. In addition to this, we have a number of studies. We have a normal study that we're collecting 8,000 normal lumbar spines and 8,000 cervical spines of non-symptomatic patients to really do the same thing that, say, a DEXA scan does with the World Health Organization on a Z-score, T-score approach, because not everybody's spine, if you think about mine versus my grandma's, not everybody's spine, from an instability standpoint, could be categorized as unstable identically, right? So it's depending on what the numbers are.
VMA is a system for assessing spinal motion, including lumbar and cervical radiographic instability.
And I'll talk through this in a second.
To the standard flexion, extension, bending X-rays that are currently used to assess spinal motion and instability. The VMA uses special hardware to assure patients fully bend during imaging. Bolsters and controlled motion promote consistency and reliability. The bolsters keep patients from bending at their hips to assure that the back and not the hips are in motion during imaging. Current testing methods tell patients to bend on their own without constraint. Thus, they often bend with their hips versus their back. The cervical VMA operates on the same principle as the lumbar configuration. Bolsters minimize torso motion, while the device provides controlled motion. Patients use the device as a tactile guide that assures they bend sufficiently during flexion and extension imaging. These images are then pushed to a HIPAA-compliant cloud system where they are processed to produce highly accurate and repeatable measurements of intervertebral angulation and translation at each level. Results are accessed online or through a PACS system. Spinal motion can be visualized, and detailed quantitative reports are provided that include user-set red and yellow light instability alerts. These alerts make reading VMA results very quick and efficient. Variables in patient bending can be minimized when utilizing the VMA. It can help uncover spinal motion and instability that may have otherwise gone undetected. It can also help rule out concerns about spinal motion and instability, in many of these cases providing surgeons increased confidence in choosing a more conservative procedure.
And so when we talk about this, one of the questions that comes up is, how we drive them through a bend. It's a tactile feedback, right? Proprioceptive mechanism where they follow the bend range. So if that individual just stood up, the machine would move around them, right? The other thing is we oversample. So basically our algorithms are like facial recognition software. So once the vertebral body is evaluated the first time, it's tracked over 128 frames in both directions. So the algorithm actually tracks the vertebral bodies, produces a quantified report that's purely objective, right? No subjective measurements in terms of trying to mark up the system. It's all tracked automatically. And so we have a number, obviously from a scientific standpoint, around the performance of the device, and we're moving into the clinical side of it as well. One of the questions that was talked about a second ago was the sensitivity of the test. So actually from a prevalence standpoint, we identify about twice the rate of radiographic instability in motion. A lot of the rationale for this is because in a standard FlexX, right, typically, as I mentioned, they underbend. The patient doesn't go through a full bend range. A lot of times And if there's any rad techs in here, sorry, but a lot of times we'll be in the room when they're shooting the films, and okay, stop there. That's a good film. Stop, or stand back up a little bit straighter. Let me get a good shot. And so that's not a true flexion extension view of what's going on either from a lumbar or cervical standpoint. And we can talk about all of this data as well. Now from
For
a
example, this case study
case
shows
study,
a
and I'll show you
two-level
these in just a
C4
second when I pull
to
up the
C6
portal.
fusion. There was concern regarding the C3, C4 level. In assessing spinal motion, the VMA allows a physician user to drill down to a specific level. Here, at C3, C4, using the VMA, the physician determined that there is radiographic instability, which is apparent in extension. The patient showed no evidence of this instability on standard flexion extension x-rays. This tends to happen if patients stop short and do not bend completely, which can easily occur if patients do not have anything to appropriately guide their spine bending. The patient had an unremarkable MRI, yet she was incontinent and in severe pain. Supported by the VMA results, as evaluated by her physician, the patient underwent a fusion surgery at C3, C4, and symptoms were completely resolved.
And so I'm not a clinician, obviously, and you guys can talk about this. This was a patient that had actually fallen and had incontinent and couldn't figure out. They did an MR CT. There was nothing. They did a FlexX. She underbent. They took her through the VMA, and they found at C3-4 there was an issue. Now, sorry.
So wait, if I can interject there. So the speaker a second ago said that this was trying to minimize surgery. This looks like something that looks to have more indications for surgery rather than less.
So that often comes up, and so what we say, while the prevalence is increased, this is identifying radiographic instability that wasn't identified previously, but more importantly, it's more of a treatment decision algorithm type of approach where not necessarily the fact that the instability is there, but it may change the decision from a conservative care standpoint. It could be a surgical standpoint, but again, from a big picture standpoint, as you identify instability that wasn't there previously, likely it would change a decision, not necessarily increase the surgery amount, but more from a surgical decision standpoint. And so we have. I'm not going to go through each of the studies, but from a general standpoint, we have a number of publications that are published that talk about the clinical validation of the system. This is a recent study that actually started to look at proper cage placement and how it impacted motion as well. And then a number of reasons in terms of sensitivity, specificity, how it can impact decision processes. More recently, what we're coming out with, can you go to the PDF, is more and more the information on sagittal alignment is becoming important. So again, this is a computer, an automatic system. So once you go through the bend profiles, we identify the vertebral bodies. We actually have a system coming out late July on sagittal alignment measures. So the reports that I'll show you in a second on the portal, we also have sagittal alignments. This is a no user interface approach. Once the images are taken and they're processed on our side, we'll provide data not only on angulation, translation, disc height, but we also have sagittal alignment measures, so your PI versus LL mismatch. All of this will be completely automated where there's no input on your side. The end of the year, we actually have a VMA OR system that is finished development where all of this information from your FlexX views and your dynamic views, both upright and lying and lateral bends, will be fed into an OR system where you can take your fluoro and scouts and then basically identify information during the OR, much like IGA does with Nuvasive and some others. There'll be no interface on your part. It'll automatically all be fed in, so it's a very user-friendly system. And again, the rationale behind the significance of why this is important. I think all you guys are pretty familiar with the idea that sagittal alignment matters now, and that sagittal alignment is going to be important from a surgical standpoint as well. And so let me show you. I'm actually going to walk to the back and run through this portal. Let me show you what. And can you guys still hear me? Okay. So as I mentioned, this is where the physician's data would go. All of your simple images would get pushed directly to PACS. This is a dynamic view. Over on the right-hand side of the screen, you can see we have red, yellow, and green markers. Those markers represent what we did was we went into the literature and identified the thresholds of instability that are in the literature. So did a meta-analysis of what people considered radiographically unstable based on a measure. If it's a red light, it falls above every measure that's in the literature. So that could be 3.5 millimeters, that could be interqual, millimin, AMA, whatever those measures would be. This is fully customizable for what you guys would have. So if we look at a specific patient, you would just click on that patient and you could open up, and this will load up from a cloud. Which one? Green. So this is a cervical example. What we have here first is a dynamic report. So all of this data is quantified through the algorithm, nothing manually having to be calculated by the physician. Any piece of this data that has a box around it, for instance, is you get the static views. And so these are pure static films off of the dynamic bin range. Anything that has a graph, what we like to say is we have quantitative data as well as qualitative data. Anything that has a graph is actually a video. And so this is a level by level evaluation. And so we can play through that level by level evaluation. What we have there on the bottom, you can see this is neutral. If you see my mouse down here, this is neutral, flexion, neutral, extension. So anything that has data behind it has either a static film or a motion film. But more importantly, when we look at this, this is the whole system. So what we have from a qualitative standpoint is the views. From a quantitative standpoint on the left-hand side, these are kinematic traces. So this is a time series data point. What we can do is look at the whole system in motion, drag through and look at the whole cervical system. We can take the trackers off and just look at the motion profile. But through the sensitivity of the test, one of the things that's important to see is if you look over here on the left-hand side, these are supposed to be pretty sinusoidal type of curves. Smooth motion would make a smooth graph. Anytime you have a big dip, that means that motion between those vertebral bodies is changing very quickly. Any of these graphs we can click on and drill down to those specific levels. Now, if you remember in this case, 5, 6, and 6, 7 are fused. So this is a good example of the sensitivity of the test in terms of the view. So this is obviously a fused segment. If you follow the motion when I hit the graph, you can see right here as it opens up and you can see light behind it. This is where the sensitivity of the test is important when we're looking at, say, fusion, where we can see here non-union, where in a FlexX you wouldn't have seen that based on the sensitivity of the FlexX. The more importantly is we can look at these reports and you can see down here the fused segment in this case at 5, 6 was about 3 degrees of rotation. The adjacent level, the lower level, about 1 degree. You can see the change in motion profile on the adjacent levels as well. So this is consistent with both a cervical as well as lumbar motion. So we do the same thing from a lumbar standpoint and provide angulation, translation, rotation, disc height measures, sagittal alignment measures through the whole bin range. So not just the standard, just the static in ranges. Again, all of the information can be pushed to PACS. Everything's customizable. So in addition to this, Mike, open up a RAD report. So all of this is dynamic in view, but then you also can provide, just exit out of that. So all of that data right there that's quantified can also be pushed, and you can generate, just go to there's a paper version of this that can be pushed to packs. You can print out, you can put in your records. Has all the image as well as all of your data. But then in addition to that, open up a radiology read report. In addition to this, all of the data that you talked about before, this could be dictated off of. So all of those measures that were quantitative in terms of the millimeters, percents, rotations, whatever they would be, can also be generated in terms of a read report that can be dictated. It can be pushed to packs. It can be printed. It can be put in the charts. And all of this information is customizable back to the system. If there's specific terminology, if there's specific information that you want to provide in the records, you can type that in at the beginning one time, and all of your reports will be generated consistently in terms of terminology.